Lovely. Okay, so for this evening's teaching session, it's on urgent glaucoma referrals, and I'll pass you over to Miss Obi.
Yeah, can you all see that now?
Yes, thank
And
you.
you can all hear me. Okay, all right. And if I talk too fast, stop me. Yet to learn how not to do that. Okay, so urgent glaucomas. I'm going to down. Okay, so we're going to cover urgent glaucomas. Southeast London glaucoma referral criteria, which I updated slightly for this talk. We'll go through some general things around referral guidance, what to do if people are already under the hospital eye service and they've either been lost to follow-up or they haven't received their expected appointments, or there are new findings that you're concerned about. Just a little bit of a thing on miscellaneous stuff, and then a summary to round up. And do feel free to stop me anywhere. I've had to close down my screen of people's faces, so I won't see your hands, but just shout out or whatever you need to do, okay? So let's talk about some acute glaucomas. So I know when people think of acute glaucoma, the first thing they think of is, oh, this must be acute angle closure glaucoma, but just a reminder that it isn't, okay? So yes, a lot of them will be angle closure. Primary quite often is one we worry about, but remember there are already also secondary angle closures, but we can also have primary open angle glaucoma and secondary open angle glaucoma presenting acutely. Okay, so it's not everything is angle closure just because it's a high pressure that's happened suddenly, or a patient thinks it happened suddenly. So that's just a reminder about the sort of things. So yes, when we have someone who has primary angle closure suspect who then develops acute angle closure, that becomes primary angle closure. So they now have a raised IOP and symptoms and signs, and that sometimes we put acute in front of it just to stress that actually it was of sudden onset, that change. Primary angle closure glaucoma patients can also appear to present acutely just because they present to you with a really high pressure and then you assume it's an acute finding. Primary open angle glaucoma, one of the things when they've just not taken their medications, and definitely got patients like that. And then they're the secondary glaucoma. So if they've had surgery, particularly retinal detachment surgery with silicone oil, or they've had recent blunt trauma with hythema and so on, the pressure can go up. Poschner-Schlossman, which is a hypertensive uveitis where they get a trabeculitis, can present acutely, and uveitic glaucomas can present at any time, and they will all start off generally as open angle to start with. They become angle closure when they've developed significant peripheral anterior synechiae as part of the uveitic process. And then obviously there's the neovascular ones, which again will, if you catch them early enough, will be open angle, but a lot of them we see when they're really quite advanced and they've zipped open the angle. So I'll go through these. So this is the sort of thing that people often think about when they mention acute glaucoma. So, you know, it often is angle closure, but it may appear in open angles as well. So do look at the other eye, okay? If the other eye is a deep anterior chamber, then this may not be acute angle closure unless there's something very different about the size of the eyes. And we know that primary angle closure disease is a disease of anatomical disproportion. So the front segment of the eye, the anterior segment, and the posterior segment are smaller than average. So these patients will sometimes present to our main A&E with headaches, nausea, vomiting, halos around lights. The eye will be painful, they'll be photophobic, there'll be reduced vision, and this is because the cornea becomes edematous with a sudden rise in pressure and the inflammation that causes. And it's that inflammation that happens because of the acute pressure rise that actually gives them their symptoms. If the pressure goes up slowly and you don't get inflammation, you do not actually have symptoms until usually you get to the point where either the pressure is so high it's affecting the endothelial function, or it's so high it's compromising retinal circulation that people become aware of it. So they will have the typical one with inflammatory, with inflammation associated with it, will have a hazy cornea and a red eye as well, and it will be quite painful. And then to touch, the eye can feel quite firm, and the pupil in a typical case is dilated, unreactive, or only sluggishly reactive. So those are the typical sort of things. So this is a typical kind of eye. They can be precipitated by pupil dilatation in patients who are at risk of angle closure. So those are typically your smaller eyes and your hypermetropic eyes, and the more hypermetropic, the more likely. They do, we find in the hospital, sometimes get misdiagnosed as a neurological emergency. So let's say they've gone for diabetic screening, both eyes have been dilated, then they come with bilateral eye pain, for example, most people, and then they come with this horrible headache, nausea and vomiting, and they turn up in accident and emergency. The first thing our general medics, who have very limited ophthalmic training, would think about is, oh, this person has a subarachnoid hemorrhage or some sort of neurological emergency. So some people do sometimes get missed for that reason.
Miss Obi, can I ask a question?
Sure.
Based on the comment that you made earlier about precipitated by pupil dilation in patients with small risk of small angle closure,
yeah,
there are often situations where we are required to dilate a patient and there is doubt whether it's safe to do so.
Can I cover that? Can I cover that later, because it's in my miscellaneous section?
Amazing.
I'll come to that. Is that where?
Thank you so much.
Okay. Okay. So this is a. Oops, sorry. So that's a typical sort of acute presentation in someone who's got angle closure. Okay. This is someone who had sickle cell retinopathy, had a tractional retinal detachment, had an open angle. Okay. He'd had recent surgery and he presented with symptomatic, really quite uncomfortable. The vision had gone down in that right eye, partly from his sickle cell retinopathy and the tractional retinal detachment to 636. Van Herrick was narrowed 10%. His IOP had gone up to 35. He had a lot of inflammation in the anterior chamber, which is why he was symptomatic. So this was about a week or so after his retinal surgery. He was in iris Bombay. He had a lot of flare, cells, and pigment in the anterior chamber, because quite often there's quite a bit of pigment shed during retinal surgery and with all the dilatation and everything. Now, I have to admit, this is not his photograph, but it looked very much like him. Okay, so he was secondary angle closure, not glaucoma, because he has healthy optic discs, 0.3 on the right compared with 0.2 on the left. And you can see that the left eye, the pressure is 12, the anterior chamber is deep and quiet. Okay, so when there's a big difference between pressure, big difference between Van Herrick, you need to be thinking about a secondary cause, okay? So this is a secondary angle closure from iris Bombay. So there's been a lot of inflammation in the eye following the retinal surgery, and the iris has stuck down to the pupil, and obviously there's no circulation of fluid. So then he had to have a surgical, he had to go back to theatre, he had cataract surgery, had a surgical iridectomy, which again closed because of all the inflammation, and so I had to give him an injection of something to help open it up. But this is someone that might present acutely to casualty, so asking about if there's a big difference in the eyes, you need to be looking for why there's a problem in one eye and not in the other. Okay, so he had a surgical iridectomy, and then after a while, because the PI he had initially when he presented urgently was no longer patent, and then over time the surgical iridectomy closed with the inflammation. He had a lot of fibrinous uveitis, and patients with sickle cell retinopathy can behave like diabetics. They get inflammation very quickly. A lot of them are black in London anyway, and black and Asian people, so the more pigmented your skin is, the more inflammatory response you tend to have to things. The darker your eyes, the more inflammation. So what we did was give him this intracameral alteplase, which basically breaks up fibrin and so on, and it made the surgical iridectomy patent again, and then there was flow, and then things settled down. So this is one person that might present acutely to you. Quite often they'll come to eye casualty because they've been in the hospital, but they may, you know, particularly when patients are away from home, may end up in your optometry practice, and you may have to tease out the fact that they've had surgery if you can't recognize the fact. This is someone presenting with, and anybody think what I'm thinking, what I might be alluding to for this patient? What might they have? Anyone? Any ideas? Anyone? What might this be? No? Okay. All right. So this is a patient with neovascular glaucoma. All right. So these are the stages that neovascular glaucoma can present at. So this top right picture, you can see all the limbal injections. So they're acutely inflamed. They've got pressure spike. They've got rubeosis all around the pupil here, and that's showing it in the picture up here, showing it a little bit more detail so that you can actually see the new vessels at the pupil edge. Okay. In the beginning, they'll have these abnormal vessels when you look at the angle. So neovascularization of the angle as well as the iris. So of the iris, we call rebiosis. Of the angle, it's neovascularization of the angle, angle neovascularization. The IOP is normal in stage 1. Over time, the neovascularization becomes worse. They develop a fibrobascular sort of membrane of the trabecular meshwork. So now that's impeding outflow of aqueous. So your aqueous outflow goes down, your intraocular pressure goes up, and over time, then you move to stage 3, which is the final one that we often see patients at, where the whole angle is zipped up by this fibromuscular membrane, which contracts, and then the iris gets pulled right up to the cornea, so you can no longer see pigmented trabecular meshwork like you can there, slightly there behind all those blood vessels, and now it's zipped up completely. So now there's no outflow, and because the iris is being pulled into the cornea, you may start to see they've got this thing we call ectropin uvea, so your posterior layer of pigment at the back surface of your iris now gets pulled anteriorly because your anterior stroma is being pulled into the angle, so it's pulling the pigmented area, and you start to see some unusual, like an extensive pupil ruff on the anterior surface of the iris. They can have inflammation, and quite often when they will present when they develop hyphema. So those abnormal iris vessels and angle vessels start bleeding, then you get blood in the anterior chamber, you get inflammation, and that makes them symptomatic, and that's when they'll present. So they may not have been too aware of it initially, particularly if their vision was very poor already, because they'd had, say, a central retinal vein occlusion, and they'd lost, the vision had dropped from that reason. So this is a patient who presented in, so now we've gone, let me go back. So we talked about acute presentation from angle closure. We've talked about an acute secondary angle closure. We've talked about a neovascular one, which can be secondary angle closure, but can also present with open angles. And now we're coming on to this case, which was someone with uveitic glaucoma. Okay, so presents to casualty the pressure of 56 on the right and 18 on the left. They've got inflammation, so they're symptomatic. All right, they're actually secondary angle closure. They haven't got glaucoma at this time because the optic disc is healthy. Okay, so when you do gonioscopy, you can see all the, actually I lie, they did get glaucoma a while over time. So here they have primary angle closure, so you can see secondary angle closure, you can see all the PAS coming up to, some of them high up to the, covering most of the trabecular meshwork, others just to the bottom of the trabecular meshwork. Over time, the cupped disc ratio increased from 0.6 to 0.85. So at this point, they do have glaucoma. You can see how cupped the disc is there, and that's our diagram. And then you can see the field defect associated, that superior rim loss. Okay, so they got thin corneas, they're on COSOPT now, the pressure's down to 15, so that's controlled, but they've got glaucoma now because they had repeat episodes of uveitis with increasing inflammation, increasing pressure spikes, and over time they became uveitic. So that's the PAS, and that's what the OCT looks like. So again, you can see the thinning of the ganglion cell complex and in the circumpapillary retinal nerve fiber layer as well, matching the cupping and the thinning superiorly, maximally of that optic disc. So that's another patient that presents with acute presentations and presented initially as an open angle with inflammation, and then end up with a closed angle. This is another patient who presented with to eye casualty with recent zigzag sort of something in their central vision in the right eye. They had blurring and ache, and they noticed halos around lights. Now, if you look at the cornea, this is a good picture, although I don't have a picture of the patient. You can see the cornea still looks quite clear. When you look at the endothelium, you might see the occasional KP, small KP, but not much in the way of inflammation at all. And you can see that there's very fine edema in the cornea. The pressure's high at 50, just the occasional cell, the occasional flare. Van Herrick is wide open, so that's not typical presentation for angle closure. Discs are pretty healthy, and this person had a non-granulomatous anterior uveitis, so tiny KPs if you see them, the occasional cell, and for this is Posner, someone with Posner-Schlossman, and where they're assumed to have a trabeculitis, so there's acute inflammation at the level of the trabeculum, and that causes the pores within the trabecular meshwork to narrow, and so that reduces outflow. Then the pressure goes up quite quickly. They get some inflammation along with it, a little bit of endothelial dysfunction, mild corneal edema, so they'll get the halos, a bit of blurring, but they don't get the frank corneal edema and massive drop in vision that you would see with someone with comes typically with acute angle closure. Okay, and nowadays we know that that's highly likely that they've got a CMV infection. So we will tend to take a sample from the anterior chamber of the aqueous, send it off for analysis, and if we do find CMV, then we'll put them on antivirals, and that can help reduce the frequency of the attacks, which can be, for some people, once every 2 years, other people every few months. And each spike in pressure can be enough to cause a problem with to the optic disc over time. And then they may go from just having hypertensive uveitis, basically ocular hypertension due to uveitis, to actually having frank uveitic glaucoma. So what do you think? You want to know what to refer. So this is a pretty complex charts there. So you've got your referral categories, your P1 is that's really urgent, P2 which have a priority, and P3 which are routine. Okay, so P1 are those with a pressure of 35 or above. Those ones you can refer straight away. We do expect for MECS optometrists to have done it with Goldman or Perkins tonometry, unless there's a reason why you can't. If you can't, you can, and the pressure's not too high, you can send them for referral refinement, but you need to do that within a few days, and then send them to us. Okay, so we'll see them in casualty for the most part, because it's very unlikely that a referral via a single point of access will get to us within 3 days. So those will tend to go to the closest eye casualty first to triage. The second group then would be our priority ones. We want to try and see them within a month. So when you're doing your referral, we need you to put information that will allow us to understand that this is an acute problem and that it's an urgent thing. We are, St. Thomas at the moment, we take in turns to triage, and our referrals are generally triaged within a few days of them arriving to us. Sometimes there's a bit of a delay getting them to us, but usually it's very rare that it'll be less than a week. It'll be more than a week from you sending them to us, getting them. So if there are different reasons why you might refer, so if they've got glaucomatous field loss in 3 or more quadrants, you can send them to us. We do want you to refine your field, so those fields should be reliable. We don't want that just because they put in a poor field. And we do want you to repeat them if they're unreliable, and repeating them doesn't mean just doing it 5 minutes later and getting the same unreliable result from a patient who's tired, which someone did recently. So if they've got extensive field loss, that would class as an urgent, as a reason for a priority, and we'll try and see them within a month. If their pressure is between 30 and 34 millimeters of mercury, so not quite up to the 35 of the urgent group, then irrespective of any of the features, we're happy to see them. But again, we want Goldman or Perkins pressures. If you've got 2 or more of the other features, so if the IOP is 24 to 29, if they've got a cup disc ratio of 0.8 or worse, or they've got focal rim thinning or a disc hemorrhage, that would class as one of the features. If they meet the PAX plus criteria, that's another one. And if they've got glaucomatous field loss in 2 or more quadrants with a reliable field. So any 2 of those criteria would allow them to be prioritized. Obviously, you need to assess for their PAX plus criteria. So give us information about their refraction, about family history, about being on medications, if they or any sort of SSRIs or anything that you might think might predispose them to acute glaucoma. Then the routine ones, which is a majority of, I think, most of the referrals, say King's they all go to a virtual thing for assessment. At St. Thomas's, we haven't managed to set that up yet, so they still come straight to us, so they end up with a face-to-face appointment. For these are the patients whose pressures are anyone whose pressure is between 24 and 29, okay, and again done with Goldman or Perkins. If they've got cup disc ratio of 0.8 or worse, or focal rim loss, or disc hemorrhage, or they meet the PAX plus criteria, or they've got something that looks like a glaucomatous field defect, nasal step or arcuate defect, asymmetry in the applanation of 8 millimeters of mercury or more, or an optic disc asymmetry of 0.3 or more. All those would be things, but they would just be seen routinely. And our routine appointment now is running about 6 months, I think, for us and King's. We don't want to refer them just because the IOP was done with non-contact tonometry, which people are doing, unless there are other reasons why they refer. So if you've done raised non-contact, but you're showing us the cup disc ratio is 0.8, or there's disc hemorrhage, or they meet PAX plus or something else, then that might be allowed, but that can't be one of your 2 criteria for referral, for example. Okay. Corneal pigmentation on its own with nothing else, just to ask us to look for pigment dispersion if they don't have a raised pressure, is usually not a reason for us to see, because we wouldn't do anything. We don't intervene at all. We just monitor them. And just remember that not all field loss is glaucomatous, okay? I know that, you know, if you've got other things that are really worrying and the vision is down, something you might want to refer to us, and we're easier to get an appointment with despite the 6-month wait than our neuro-ophthalmology colleagues, but just do try and send us ones that are actually glaucomatous in pattern, okay? We have talked a little bit on that is added at the bottom of this thing now, which we'll send out to the single point of access so they know. The KCH patients, the KCH team wants anyone you pick up anything and their patients are already under their care or have previously been under their care, they still want a fresh referral. Whereas St. Thomas's were a little bit different, and we want you to just to contact us. And I'll go through that later on about how to do that. Now, the other thing I was thinking about, you know, this is really very busy. So I was thinking about how to make it a bit easier. If the IOP is 35 or greater, it's an urgent, okay? If it's 29 or less, then they're likely to fall into the routine category. If the pressure is between 30 and 34, they're likely to go into your priority. So as long as you meet the criteria of you've had a Goldman or Perkins tonometry and you've sent us a reliable visual field test, they're likely to be suitable for those groups. So this is a referral that I got recently. So this is a MECS referral. Patient was sent with a painful left eye. The findings were that the patient was on travoprost, Nocte to the left eye for ocular hypertension. They were also known to have dry eyes and on ocular lubricants. They had good vision. The intraocular pressure was measured with non-contact tonometry, was 9 millimeters of mercury in both eyes. They noticed mild corneal staining in the right eye and severe corneal staining in the left. Now, this was sent to us as urgent because of the increased corneal staining. The patient was, obviously, as I say, known to have dry eyes and was already on treatment, but they were only using it very occasionally. They were on travoprost preserved at that time to the left eye for normal tension glaucoma, and they'd been known to have excellent intraocular pressure control in their treatment over the time that they'd been under us. So this patient, when we got the referral, when I saw it, we just decided, okay, we're going to call the patient so that this does not actually need a referral. And we managed to manage the patient on the telephone. So I think there's some take-home things about what the average MECS optometrists might be able to achieve by themselves. So, you know, we discussed with her, we changed the travoprost to preservative-free because we know that some people are particularly sensitive to preserved drops. And if they're known to have dry eye disease, we do try and put them on preservative-free drops if those are available. And travoprost is available, preservative-free. And then we'll talk to them about increasing their tear film supplements. And it makes sense that this person with dry eye disease has mild corneal staining in the right eye that is not on treatment, but a lot of staining in the left eye where they're on a preserved treatment, okay? So I think one of the first things you could have said rather than something urgent is, you know, when there's no evidence of infection or anything, they're known to have dry eyes, you know, talk to the patient about their dry eye treatment, increase the frequency of that, and then let us know about the fact that, oh, you've picked up the fact they're on a preserved drop. And sometimes we will know patients have dry eye disease. We prescribe a preservative-free drop, and over time their GP or someone changes it to preserved drop unbeknownst to us. And so they come in with their preserved drop, and we think all the time they're on the preservative-free, which is written clearly on our prescription, and we assume that's what they're on. So if you pick up that they're on a preserved drop when they've got a dry eye and you think they're symptomatic from that, please tell us. If it's St. Thomas's, and again, I'll come to how you can do that. And with King's, I'm afraid it requires another referral. This was another patient. This was not a MECS referral. It didn't come from here, so from our MECS people. So just for an example, so the referral was for floaters and a visual field defect. So the person had floaters ever since they'd had a PVD in 2024. They'd had a hemorrhagic PVD, so they had some red cells floating around there. They've been seen at St. Thomas's in 2024 by their by the vitreoretinal team. There were no breaks or anything in the retina, and they felt there was nothing that needed to be done. And their vision was good. The pressures were normal in both eyes when they were seen at St. Thomas's, and they were normal with the optometrist as well. But according to the optometrist, this person had a persistent arcuate defect in both eyes, and that it was a repeatable field. But what they'd done then was refer the patient initially to more fields because the patient wanted to have vitreoretinal surgery to remove the floaters because they were tired of the floaters. So they initially got sent to not from here, so here, sent to Moorfields Eye Hospital, who then said this patient is outside the catchment area, has been under your hospital in the past, send it back to St. Thomas's, and so that's how they ended up with us. But the optometrist had referred it as urgent. The patient must be seen urgently because they've got a family history of glaucoma, okay? They got that normal pressure, and what they insist was an arcuate. They'd taken the fact that the visual field was really very unreliable. They repeated it, but they repeated it within 2 minutes of the first one, and with apparently no better understanding of the patient how to perform the test. And there was no disc assessment. So I downgraded that from urgent because an IOP of 11 with a non-reliable field and no knowledge of what the optic disc is like doesn't classify as an urgent referral. But the patient has now been calling us because as far as they're concerned, the optometry said we would be seen urgently within 4 weeks, and we haven't managed to achieve that, so they're very upset. So I would say don't overpromise patients what we can achieve when we see them. And if you do really think we need to see them urgently, provide the evidence that will allow them to see them urgently. And remember that any patient we see urgently is at the expense of someone else. So it's not like we just don't want to see them. I'm going to have to turf someone out of the new patient clinic to see a patient that you've sent that is urgent. And if we've had to take off patients, take patients off the clinic and delay their appointments to see what someone tells us is urgent, and then they come and there's nothing urgent, and or the findings are all unreliable and so on, that's actually very upsetting when you've probably denied someone who actually needed it more of an appointment. So anyway, I had to write and said that there was no evidence from their referral to suggest they needed an urgent appointment, and wanting vitreoretinal surgery because you have floaters, again, does not count as something that's urgent. So when you're sending your referrals, it's all around your communication. Try and make your communication reflect what it is that you're anxious about and what it is that we need to know to help us make a sound decision. And I'm sure, when you're referring it, you send it first of all to the single point of access. It helps them to make a decision because sometimes it's very difficult. You're trying to read between the lines as to what the person means. And invariably, if it's the communication and the information on that something is not very good, we are just as likely to make a risky triaging decision by unprioritizing someone because we couldn't see any information to suggest that there really was urgent, as over prioritizing someone because actually we're not quite sure what actually is going on, and we give them the benefit of the doubt. So make sure that that clinical situation and the priority that you're choosing actually meets the referral criteria for that patient. Do make sure you've got that quality of documentation to support your referral, okay? So we know about IOP, we really want people to measure the IOP with GAT or Perkins. We have in clinic where I will have a patient with eye care, the pressure is 9 in one eye and it's 20 with GAT. I have no idea. And it could be the other way around. It could be 15 with GAT and 20 something with eye care. I have no idea what it's going to be like. So we do want it taken with something that we can actually understand, okay? So NCT means nothing to most of us, I have to say, unless it's really high. If you're going to send us on the basis of a visual field, do make sure those visual fields are reliable, okay? So when it's one of your criteria, that's really important. We don't want, we really don't, what FDT, it's very rare that I see an FDT that I can actually make any sense of. So you might send it. It doesn't actually help if it's going to be one of your referral criteria. So if I need 2 criteria, you know, an FDT isn't going to cut it, okay? So yes, they might be suitable because for priority 2, because they've got an IOP of 27 and a cup disc ratio of 0.8 or a disc hemorrhage, but adding the FDT field to a pressure of 26 is not going to, I'm not going to find that very impressive. I'm highly unlikely to make them anything but routine. Okay, so don't promise people a timeline. Don't say we're going to see them with 3 or 4 weeks or anything, because, you know, six months is the average. Okay. So if they're under HES, why might they come to you, and what may you be worried about? So they're glaucoma related issues. And I know you were discussing that. There's a new field defect that you found compared with the last time that you did a field test, which may or may not have been a while ago. You've picked up an increase in the intraocular pressure, or they look more cupped. Maybe they could have a drop intolerance. You think they're not tolerating their drops properly. Quite often we get told that, you know, you've picked up a disc hemorrhage. Or if you do think there's a disc hemorrhage, do send us an image, because that's really helpful, because invariably by the time we see them, that disc hemorrhage has disappeared. As you know, they quite often disappear, and they may come back in the same place sometimes, or come back somewhere else. So if we're going to increase the risk for that patient and maybe add extra treatment or something to them, it would be really helpful if we know that that was a true disc hemorrhage. It can sometimes be quite difficult. I mean, today I had a patient I was looking at with disc hemorrhage, and I actually got one of my colleagues to have a look and say, you know, what do you think of this? And they're going, oh, there's got a disc hemorrhage. I'm like, okay, fine, I feel happier, because it was a slightly odd shape in the depths of the cup. Okay, so, you know, we have the benefit of having 2 or 3 people to ask, and you often don't, but have a photograph. And I have definitely sometimes had to look at someone, and actually what they've got is an unusual position of a blood vessel, but taking a photograph lets us know where to look. Okay, the bigger the image, the better. You know, a tiny little disc image in the middle of the fundal photograph or the OCT is very rarely going to show us the information we need. If you can't take a photograph, describe the position. So if you say it's inferiorly at 5 o'clock, it's in the right eye temporally, wherever, I know where to look. And if the disc hemorrhage has disappeared, I know where to be expecting possibly a new, progression of the retinal nerve fiber thinning. Okay, so it can be really helpful to know that. Then there are the non-glaucomatous new findings that you might have. Quite commonly, that's a reduction in vision, symptomatic cataract. The reduction in vision can be for various reasons, either because they've got cataract, either because of their glaucoma. You know, sometimes that's diagnosis of exclusion, trying to work out what is the culprit for that. And often it's a little bit of everything adding to that drop in vision, including dry eyes. So don't overlook that, and an uncorrected refractive error. So, you know, if they've got symptomatic cataract, do include their up-to-date refraction, whether the vision could be improved, because for some people, actually, the problem is that they're just forever, you know, they're getting increasing nuclear sclerosis, which is giving them a myopic shift. So their refraction is changing constantly to keep up with that. If we don't usually offer surgery if the vision, actually, the correctable vision is very good, unless we've got evidence that actually this refraction is changing frequently. If someone has to keep changing their glasses every 6 months or something because the refraction is going, you know, getting more myopic by 1 diopter or more, that can be very difficult to keep up with. And for example, one of my patients who went from -3 to -13 because of nuclear sclerosis, obviously that's not manageable when the other eye is -3. So we'd want to know about that, but knowing where they started from would be useful. So that helps us exclude amblyopia or other things that may be the reason for the difference in refraction. Ensure that the person is happy to proceed with surgery. So don't just because you see a cataract or some lens opacity, assume that this has to benefit from cataract surgery and needs it urgently. Do assess the glaucoma severity. I mean, I did get a referral from an optometrist at Moorfields a year ago, going on about how this person needed urgent surgery because they had cataracts and they had the glare and blurring of vision. And you look at the optic disc, I had a pretty good view of the fundus. When I looked at the optic disc, it's 0.9, 0.95. There's kind of a bit of rim pallor along with that, and they've got extensive field loss. Now, there's a probably 80% chance that person's symptoms of dazzle and glare are due to the advanced glaucoma, not the little bit of cortical cataract that they had. Taking out their cataract would probably give them maybe a 20% improvement in vision, which is not actually very relevant. And if we do it, we need to give them realistic idea of what is achievable with the surgery. Okay, we also have to bear in mind that someone who's got advanced glaucoma, you know, the pressure does spike up during the surgery when we're doing a cataract and in the few days, particularly first week after the cataract surgery. So all those spikes in intraocular pressure can cause worsening of the glaucoma in that short period. So we do need to make sure that we're offering them cataract surgery for the real reason. Okay, and they also need to be aware that that cataract surgery is not going to overcome the vision loss that is due to glaucoma. So make that clear. And then if they're happy to have the surgery, that's fine. But we do get a lot of patients referred, you know, this person has cataract. Yes, they have a bit of cataract, but that's a tiny part of their problem. Okay. And the other thing is, if they do have cataract, you do want them to have cataract surgery, and particularly they're under St. Thomas's, we want them to come back to us. Okay. I had a patient end up that I had told I would not do her cataract surgery because her glaucoma control was poor, her compliance with treatment was poor, and I was worried about her. And I was convinced that one eye was amblyopic. At the time, she was 680 in the eye I thought was amblyopic and 6'9" in the other eye. Okay, and she'd been told when she saw optometrists that she had cataracts. And I'm like, your pressure is 30. Okay, we need to get your pressure under control before I do any surgery on you because you're going to spike up. I ended up not seeing her at the 2-month appointment I'd made for her. I saw about 3 months later, by which time she'd seen an optometrist, MECS Optom in Southeast London, who'd sent her to check. She'd had, I don't know what they'd done to her eye, but anyway, she came back with hand movements in the worst eye and 636 in her good eye, okay? And her pressure was all over the place, all right? But it's too late for me to do anything. I might have taken them to surgery. I might have put a mini-ject in. We might have done something else along with it, okay? Or some trabecular angle surgery to try and reduce her pressure. But that was no longer an option for us, okay, because she'd lost a lot of her vision by that time. So please do refer them back to us because we do like to look after them. We are aware that their pressure will spike up in the perioperative period. We will quite often put them on. We always put all our glaucoma patients on acetazolamide for the first 3 days, and for anyone with advanced glaucoma for up to a week, okay? Now, if they're not under glaucoma, they're highly likely to get that level of care. If they're already under HES, do ask them for their old letters. And again, for St. Thomas's, they should get good letters. They may be actually printed for them. They may have been posted to them, and they may be on their MyChart app. So do ask them, because quite often patients don't remember they have these things. If they're unknown to you, they just moved to you from somewhere and they've been under someone's care, do ask them if they have any records or their GP has records of what's been happening to them. That might give you some idea of what happened in the past. If they're private patients, again, usually if they're under someone privately, they will have pretty extensive reports a lot of the time. So again, if they bring those old reports to your clinic when you're seeing them, that can be very helpful. So again, so to summarize about if they're under HES, for those in the glaucoma service, email your report to our ophthalmology medical secretaries. Patients who are under our care also have the ability to call our glaucoma callback answer phone. So it's an answer phone. They just leave a message. That phone is only for their clinical management. So it'll be do with their medications if they think their vision is worse, if maybe they had cataract and they weren't keen to have cataract surgery, now they feel that actually they do want to, or they want to discuss something their optometrist said to them, they can call us on that number, leave an answer phone, and we will get back to them. But it's strictly only for current GSTT patients. If they've been discharged from us because they failed to attend twice, occasionally once, if they're very low risk, they're not eligible to use that number. King's wants you to refer by the single point of access again. If they're lost to follow-up, and that can be for various reasons for both hospitals, we have had quite a bit of something with the implementation of EPIC, which is our electronic medical records, which was in October 2023. A lot of patients dropped through some big, deep cracks after that, and they got lost. And we are still seeing patients that we were supposed to have seen a year ago, okay, when it was transferring from one system to another. So they can, if they just haven't received an appointment, the patient can email our appointments people, or you can if you think the person's not up to that and they haven't had an appointment. Or again, for King's, it's single point of access. And they said they want you to do that because they don't have a setup for people that will deal with their queries. So we will make a decision on urgency if it's just an appointment that's been somehow lost or missed or so on, if the appointments come to the appointment service and they can't manage them themselves, if there's anything then that they need us to something, we'll get involved in how urgent the appointment needs to be. Okay, just be aware though that sometimes patients say, oh, we never got an appointment. What they've done is DNA. Okay, they've DNA'd, there's something, or they've rescheduled and rescheduled. And if they reschedule umpteen times, I mean, had to discharge a patient recently, rescheduled 5 times this year alone. Okay, where we can't keep up with that, they will get discharged. One DNA, the first time they DNA a new appointment, it means they get discharged. If they DNA 2 consecutive follow-ups, then they get discharged. Okay, and if they've been discharged, they need a new referral unless somehow there's a really arresting case and it was somehow our fault for something. So we come on to the miscellaneous things. So Bhavina had mentioned this was a source of anxiety, dilating someone that you know has a narrow Van Herrick, so grade 2 or less. Okay, now I was looking at the evidence, and it's variable. Basically, most places will say that it's low. It depends what group of patients you're looking at. General, for diabetic patients going for dilatation and DESP, it's pretty low. It's usually about always less than 1%, usually often less than 0.1%, okay? But I did look, I managed to find while I was caught in the train getting here home today, that there was an article in the American Journal of Ophthalmology in 2021, where they looked at almost 900 patients who are primary angle closure suspects. So they've already got an occludable angle. They'd done a PI in one eye and they hadn't done a PI in the other. And they monitored, they watched them over 3 years to see what the risk of them having rising pressure and developing acute angle closure. So they said the pressure rise was roughly about 1.5 millimeters of mercury in the eyes that had the PI, about 1.6, 1.7 millimeters of mercury for the ones that didn't. Okay. But they did notice that for those that had the narrowest of the angles, there was an increased likelihood that the pressure might go up 5 millimeters or more, which makes sense. The more narrow the angle, there's a bit of a difference between someone. I tend not to use the grades, I have to admit. I find it easy to use percentage. So if someone is 0%, their Van Herrick, there's iris is right up there against the cornea, it's likely there that they've got less outflow than someone who is 20%. Okay, so those are the sort of things you think of. But then they looked at over 3 years, they found that there was a 0.1%, so a 1 in 1,000 of the patients who had not had a PI ended up with acute angle closure glaucoma over a 3-year period of being regularly dilated. And the ones that had a PI, it was a 0.03%. So it's pretty low. I mean, I'm assuming that most of the patients you're going to be seeing probably have not had a PI, the ones that you're worrying about. So, you know, being 0.1% risk over a 3-year period probably equates to about 0.03% risk over a year. So it's very unlikely it's going to happen at your visit. But, you know, you can think about the drops that you dilate them with. As Bhavina knows, in my clinic now, my default now is phenylephrine 2.5. I don't know what you're allowed to use. The general thing is tropicamide. We don't generally dilate with both of them because that does precipitate angle closure a bit more. So it's either tropicamide 1% or phenylephrine 2.5%. And I like phenylephrine 2.5% because mostly I don't usually need them very widely dilated, but the blue eyes and the hazel ones can sometimes end up with a 7-8 millimeter pupil. And it doesn't affect their accommodation. So they're pretty happy. They can sit in the waiting room and they wait around for a long time in our clinics. And they can read, they can use their phones, they can something. So they're more comfortable. If it's sunny, they will still complain about the dazzle and glare when they go outside, but they're not as incapacitated as someone who gets tropicamide. And if it doesn't work enough, I can top it up with tropicamide, but at least I can usually tell them they can go back to work and function reasonably well in the next 2 hours. If you're really worried about someone, and there are some times I might worry, I might check the pressure afterwards. Aqueous suppressants are the most beneficial. So if you have to really widely dilate someone because they've got flashes and floaters and they're myopic and you're really worried about them, it's more important to make sure that you don't miss a retinal detachment or retinal break than it is to worry about the pressure going up. If you have IP, you can give them aqueous suppressants. So you can give them Timolol, not if they're bradycardic or they have respiratory problems. Dorzolamide and brinzolamide are generally safe, and the aqueous suppressants tend to work better, and they do work generally very well if you give it to them before the pressure starts to go up. So if you give it prophylactically, if you're worried about them, if say they've dilated and the pressure's gone up a little bit, you give that to them then. I haven't yet had anyone, touch wood, that has come back in acute glaucoma. There was an interesting case. I put the reference in there that you can check about just an optometry paper just discussing various issues with angle closure and what you might want to do with them. So you might find that interesting. And I will add the reference for the AJO paper. I must just look for it and then had it. And then the other thing is, the most important thing is giving that patient information, okay? So most of the patients that do develop acute spikes in pressure and angle closure, acute angle closure after dilatation, are the ones that don't know what to do if they get the symptoms, okay? Or they just have the symptoms, know what to do, but just choose not to do anything about it. And there are a few patients who will have that attitude, and then they wonder why they're in pain 3 days later. So if you have some kind of information leaflet, you can give your patients so that they know what to do. And just remember that it's really helpful having written information or something that you can text them or whatever, because there are studies have shown that you go to your GP, and I'm one of them, I have to admit, go to your GP, your doctor, you see someone, they give you information, you only take home 25% of what you're told, okay? So they're invariably going to forget what you've told them and either over-remember or under-remember what you say. So giving them something that gives them an idea of where to go so they're not floundering can be really helpful. And there are all kinds of paper leaflets out there, and you can make your own as well. So in summary then, just remember, the biggest take home I want is that acute glaucoma is not just acute angle closure. So do ask about the history and the other things that might have precipitated them to present to you, because it's not always, it hasn't always just happened. And I say the patient I remember did kind of confuse our casualty people, because the patient came with bilateral pressures of 55 in both eyes. She had been known to be on 4 glaucoma agents, and she had decided for some reason that for the last 9 months she wouldn't take them because she's been praying instead, okay? And then she came back with pressures of 55. She came back because she'd almost had a incipient retinal artery occlusion in one eye, and she now had 0.9 discs where she'd had 0.7 before. So that can happen, okay? Do remember that your referrals tests should have the adequate assessment and communication to allow you to prioritize them according to the guidance, and do try and, it is complicated, do try and choose the appropriate priority so that you don't overpromise your patients what we aren't able to deliver. Do remember that we really do want your pressures to be GAT or Perkins unless there's some reason you can't. So if they've got dementia or something, the only thing you can do is a non-contact or an eye care, that's fine. Write that there and tell us. If you think they've got a visual field defect because they seem to not be noticing where they are and they really can't do it reliably, you've done it twice, okay, we understand that. There are some patients who 10 years down the line are still doing hopeless visual fields. And obviously, if you think they've got an occludable angle and narrow Van Herrick, we want that PAX plus assessment so we know whether they fit in. But even if they're not quite fitting in, but if there's something that really worries you, add that in, because we might take that into account, okay? If they're under our care already, we generally do want to see them again, okay? They are our patients, they are our responsibility. And again, KCH is all via single point of access. There's only one thing. And just remember that St. Thomas's, you can send your reports to our ophthalmology medical secretaries who are part of our appointments team. But if you send it that email address, the people that usually answer that email have been in the hospital for a while, and they're not chopping and changing quite so quickly. So they're much better at making sure we get those emails within a few hours of you sending it to them. And we check our emails daily. So it's unusual that we won't be able to get back to someone or do something about that patient within 48 hours. And then, and I say, we answer the callback answer phone all the time. So it's answered every day. That's a work day, not at the weekends. It's checked twice a day on average, but the patients have to leave enough information that we can make sense of it. So there's no point just garbling, tell us you have a lot problem and you don't tell us your name. They need to tell us their name, their date of birth, their hospital number, either their MRN or their NHS number. They need to give at least 2 pieces of information that we can track them down, and they need to leave their message legibly so that we can actually phone them back, because we phone them back. Okay, right. Thank you. That's what we've moved to nhs.net at St. Thomas's, so we're finally there. So that's my email if anybody has anything they want to send to me.
Thank
you very much.
Thank you, thank you. I'm going to invite the participants if they have any questions.
Did that answer the question about the whole one about
Dilation.
dilation? Yes. You think we're done? Okay.
Yes.
Okay.
Yes. I believe so. There are no questions in the chat at this point in time.
What was that comment about NVG? What was that about?
When you asked a question, does anyone know what this is?
Oh, I'm sorry, I wasn't reading that.
One person had answered.
NVG. Oh, well done, whoever that was.
Amazing. Okay, I'm going to stop recording now. Thank you.